Good morning, Singapore, and welcome to the first symposium of SingLive 2021. My name is Dr. Leslie Lam, consultant cardiologist, Cardiac Center, Farrer Park Hospital, Singapore. I'm very pleased to be hosting this opening symposium titled, It's About Time, introducing the AngelMed Guardian, the world's first implantable ACS patient alerting system. The objective of today's session are to introduce the AngelMed Guardian and how it is a better prompt than symptoms alone for detecting ST changes in patients who have had prior acute coronary syndrome events and who remain at high risk for recurrent ACS events. I personally have had recent experience of the AngelMed Guardian, having performed 5 operations in the second half of 2020. I will share with you some of my experiences, and those are my patients with you later. Joining me for this session are, from the US, Dr. David Fischel, founder and chairman of AngelMed Guardian System, Dr. Kelly Tucker, director of pacing and electrophysiology, Orange County Heart Institute, and Dr. Andrew Kaplan, director of Heart Rhythm Center, Banner Heart Hospital, Phoenix, Arizona. On completion of our presentations, we will hold a Q&A session featuring our 3 presenters and 3 panelists from Singapore: Associate Professor Philip Wong, Associate Professor Cheng Chi Kiong, and Dr. Calvin Moore. Please send through your questions and comments at any point from now. Prior to the proceeding, I would like to thank the session sponsor, Hydrix Medical, the distributor of AngelMed Guardian in Singapore. Now I hand over to Dr. Fischel to present the scientific rationale behind AngelMed Guardian.
Welcome everyone to this Singapore live webinar. My name is David Fischel. I'm the founder and now chairman of Angel Medical Systems, the developer of the AngelMed Guardian. Doctors Tucker, Kaplan, and I are here today to discuss an innovative device that helps solve the unmet need to get patients having acute coronary syndromes, including heart attacks, to quickly seek medical attention, even if they're having a silent MI. Over the next half hour, we plan to share with you what we have learned over 20 years of work to bring this potential life and heart-saving device to market. Dr. Kelly Tucker will begin by describing the problem with symptoms. I will discuss the science and technology behind the AngelMed Guardian, and Dr. Kaplan will finish with a discussion of what this means to his patients' quality of life.
Thank you, Dr. Fischel. My name is Kelly Tucker, and I was the principal investigator in Orange County, California. The topic today is acute coronary syndrome events, including heart attacks. And as you know, this is the most common form of death in the United States today. It's a huge clinical problem. And the fact is, most of these patients should not die. The dilemma is that the actual treatment of acute coronary syndromes and myocardial infarction rarely occurs until the patient acts. And the patient's actions are predicated upon 3 critical steps occurring before any therapy. Firstly, the patient has to develop symptoms. Secondly, the patient has to recognize that these are the symptoms of an acute coronary syndrome or heart attack. And lastly, the patient has to seek timely medical attention. Now, obviously, these 3 steps are quite inefficient and result in significant treatment delays and consequent increases in morbidity and mortality. So currently, recognizing symptoms is the only warning that a patient has to alert them to seek medical attention for an acute coronary syndrome or heart attack. Unfortunately, the most common heart attack symptom, chest pain, is not a sensitive marker, and it's not a specific marker of either acute coronary syndrome or myocardial infarction. And it is rarely a timely prompt for the patient to seek medical attention. It's not a sensitive prompt, as half or more of all heart attacks have no symptoms or atypical symptoms. And this is particularly true in women, elderly, and diabetic patients. Chest pain in particular is not a specific prompt because fewer than 20% of the patients who present to the emergency department with chest pain are actually having an acute coronary syndrome or myocardial infarction. And lastly, and most important, chest pain is not a timely prompt. The average heart attack patient takes several hours to arrive at a medical facility after symptoms become continuous, and 6 or more hours after initial symptom onset on average. Now, you may have seen a few studies which show medium symptom to door times of shorter times, like 2 to 3 hours. However, these are outcome studies and usually did not measure from initial symptom onset. So that accounts for these differences. Furthermore, patient education and symptom recognition has been evaluated, but unfortunately, it's not really very effective at reducing symptom to hospital door times. Now, the importance of time to treatment in acute coronary syndromes and heart attacks is well documented. The recognition of the simple factor has led to a widespread change in the clinical guidelines. In the United States, a national directive to achieve hospital door to balloon times less than 90 minutes has been implemented throughout the country. Virtually every major hospital in the United States has met this standard. Where I live in Orange County, California, which is 40 cities and 50 hospitals, 23 of our hospitals have met this metric. In fact, the clinical importance of door-to-balloon times is so widely accepted in the United States that hospitals are graded on door-to-balloon times rather than actual clinical outcomes. Now, there's been great success at reducing hospital door to treatment times for patients with acute coronary syndromes and myocardial infarctions. Unfortunately, there's been very little progress at getting the patient from their home to the hospital door. Therefore, home to hospital door times remain a major problem and one that has previously been unaddressed. This is the dilemma that we have set out to correct with the AngelMed Guardian System. Thank you. Data that Dr. Fischel will present later in this webinar is the first to ever show a means to reduce pre-hospital delay for heart attacks, and also the first means to provide an external prompt for patients' presentation with silent MI or any acute coronary syndrome. So thank you very much. Dr. Fischel will now share the rationale and supporting data for the AngelMed Guardian System, an implantable monitor that provides patient alerting for potential acute coronary syndrome events, including heart attacks.
Thank you, Dr. Tucker. In an attempt to find a better prompt than symptoms, the first question to ask would be, is there a measurable signal from the occlusion of a coronary artery one could use to identify a potential heart attack? It turns out there is a gold standard. Rapidly progressive ST segment changes without heart rate elevation are highly specific for acute occlusion of a coronary artery supplying viable myocardium. Even NSTEMIs have ST changes at the time of occlusion if you're there to see it. These findings provide the pathophysiologic basis for the AngelMed Guardian System. So what do ST changes look like following occlusion of a coronary artery? This ECG live video tracing from our early work shows the progression of ST changes during a 2-minute balloon occlusion of a human patient's LAD during PCI. It's measured from left pectoral to the RV apex using a temporary pacing lead, similar to the can-to-tip vector with a pacemaker lead. The balloon is inflated at t equals 1 minute and deflated at t equals 3 minutes. This will play slightly faster than real time, but you can clearly see the significant changes even after 1 minute of total occlusion of a coronary. Note that in a can-to-tip vector, most LAD occlusions provide negative ST shifts. When the balloon is deflated at t equals 3 minutes, within seconds, the ST changes resolve, as you see here. As you can see, total occlusion of a coronary produces a very nice change to detect. It's the other things the heart throws at us that makes it difficult. To detect diagnostic ST changes indicative of coronary occlusion is not easy. It requires a permanent monitor for years, as ACS events and heart attacks do not occur frequently, but are very life-threatening when they do occur. Good signal fidelity over such long periods will require implanted electrodes placed to see ST changes from occlusion of all 3 coronary arteries. This just won't work for short vector loop recorders or Apple Watches. A patient self-reference detection algorithm is also going to be needed, as one size does not fit all. And lastly, the ability to specifically detect acute versus long-term changes is very important. There are lots of devices available to detect R-wave-based heart rate and heart rate anomalies, but none to measure ST changes to accurately detect an occluded coronary indicative of a potential heart attack. The Guardian system is the first to do this, includes an implantable medical device, or IMD, that detects intracardiac ST segment changes using a standard pacemaker lead in a can-to-tip vector. The device is implanted just like a single chamber pacemaker. The IMD alerts patients to a new coronary occlusion using a vibrational alert, similar to a contemporary cell phone. The IMD connects wirelessly to an external device, or EXD, that provides additional acoustic and visual alerting and has an alarm silence button. A portable programmer is used to program patient-specific ST shift detection thresholds and other parameters. The programmer enables physicians also to retrieve their patient's electrogram data associated with a detective acute coronary syndrome event. The programmer is easy to use with step-by-step guides. The IMD and EXD provide 2 levels of patient alerting, an emergency alarm and a lower priority see doctor alert. Each has a distinct vibratory, acoustic, and visual pattern that meets international standards and has been validated by extensive human factors testing. An emergency alarm signals that the patient is experiencing a persistent ST segment change indicative of coronary occlusion. The IMD vibrates and the EXD beeps and shows a red flashing LED. Patients are trained to know that they need to seek immediate medical attention when they're having an emergency alarm. This is what an emergency alarm looks and sounds like. A lower priority see doctor alert signals a condition that may interfere with ST segment monitoring, including demand ischemia and heart rate abnormalities such as high, low, or irregular heart rates. As you can see in here, the alarm is 1 beep every 7 seconds and a yellow flashing LED. For these alerts, patients are instructed to call their doctor and to schedule an appointment within the next few days. One size does not fit all for detecting ST changes indicative of a heart attack. Every patient's ST distributions are different. Slow changing events that can cause ST changes like pericarditis and other heart signal anomalies like PVCs must be properly dealt with to prevent false detection. To provide accuracy, every patient's detection algorithm is customized by artificial intelligence machine learning techniques proven by more than 10 years of clinical testing. Machine learning is used in 2 areas to allow the Guardian system to learn what is normal for the patient. The first is in setting the detection thresholds based on thousands of recorded beats, and second in creating a constantly updated baseline for the patient's normal ST levels against which current data is compared. The next two slides describe these further. Getting each patient's ST change detection thresholds right is critical, as described on this slide. At the time of implant, alarms are disabled, and the IMD begins collecting data, measuring the ST levels on thousands of beats. 7 to 14 days after implant, the patient returns to have the incision scar checked. At that time, data on the collected ST levels for thousands of beats are uploaded to the programmer. These data are analyzed statistically, and thresholds for excessive ST shift are calculated automatically by the programmer, creating thresholds that are typically 3 standard deviations outside of the mean of the patient's normal ST levels, so that normal patient activity will not trigger detection. The programmers then use to download these thresholds back to the IMD, and alarms are enabled. A patient training session is then conducted where the programmer is then used to play the alarm so the patient can feel, see them, and hear them, as well as learn to use the EXD to silence them as well. Patients are instructed what to do for both type of alerts, and just as important, patients are instructed to not ignore symptoms, as no technology is perfect. Patients return every 6 months for follow-up and refreshing of threshold levels. To allow for accurate detection and avoid false positive events, it is important to detect acute ST changes by comparing what is happening in real time with what is normal for the patient in the recent past. The second machine learning method involves having the IMD learn what normal ST levels look like over the last day by creating an effective baseline from 24 hourly collected electrogram segments. Once an hour, a new 10-second electrogram is added to the baseline collection, and the average effective baseline is updated. It supplies for comparison with newly collected data a baseline ST level as set as a percentage of the average R wave height for the 24 collected segments. Now that the IMD know what's normal over the last day and has excessive ST shift thresholds based on thousands of measured beats, the IMD looks to detect an occlusive event as follows. Every 90 seconds, 10 seconds of electrogram data is analyzed. Sinus beats are compared to the effective baseline to see if the ST level for the beat has shifted more than the detection threshold. If 6 out of 8 beats are shifted, the IMD waits 20 seconds and then grabs another 10 seconds of data. And it does this in successive segments. If 6 out of 8 beats in 3 successive segments are shifted, the Guardian initiates an emergency alarm. The Guardian then saves for later review all 24 baselines and additional electrogram segments from before and up to 6 hours after the detection. This complex algorithm has been refined and tested over many thousands of patient years, including the ALERTS clinical study. The ALERTS study enrolled patients at high risk for recurrent ACS events. The inclusion criteria required a prior ACS event or CABG and an additional risk factor of diabetes, renal insufficiency, or a TIMI risk score of 3 or greater. Exclusion criteria included no chronic arrhythmias or cognitive and physical inabilities. It also eliminated patients with life expectancy limitations or an existing PACER or ICD. The ALERT study enrolled 1,020 patients. Ultimately, 910 were implanted and 907 were randomized for 6 months to alarms on or alarms off. The follow-up rate in the study was 97% at the end of the 6-month study period. Patients in the alarms on group had fully functioning devices. Patients in the alarms off group had devices with detection enabled, but alarms disabled and knew it. The alarms off group was to represent standard of care, where only symptoms could prompt presentation. Detection being enabled allowed for the device to record when it detected potential occlusive events. At 6 months, alarms off patients had their alarms turned on. The characteristic of the patients at high risk for recurrent ACS event were well balanced between the randomized groups. The mean age was approximately 60, and 1/3 of the patients were female. At baseline, the mean ejection fraction was 54%, about a half were diabetic. Nearly all of the patients had a history of revascularization, and about 1 in 6 had renal insufficiency. 2 analyses of these data from alerts were performed: an initial analysis using only the 6 months of randomized data, and an expanded analysis that included more than 1,500 patient years of alarms on data. Different endpoints and event committee prospectively adjudicated the data for each analysis. Together, these analyses were used by the American FDA to grant PMA approval for the Guardian in 2018. FDA approval as safe was based on meeting the primary safety endpoint of the initial analysis and more than 3,000 patient years of additional safety data provided in the expanded analysis. FDA approval as effective was based only somewhat on the initial analysis of 6-month randomized data. The approval was based primarily on the expanded analysis, including additional results related to device accuracy that were not part of the original study endpoints. The Guardian system is safe and easily met the safety primary endpoint used for pacemakers of greater than 90% freedom from system-related complications, with a greater than 96% freedom result. Treatable infections at the implant site were the most frequent system-related complications, as they are with pacemakers. The Guardian system was shown to be effective by showing it's a more accurate prompt for ACS than patient symptoms, by reducing false positive ER visits compared to patient symptoms, by getting patients with symptoms to the hospital much faster than symptoms alone, and finally prompting patients having a silent MI to seek medical attention. This is a first ever. There are 2 indicators used to measure accuracy of the Guardian alarms as a prompt for ACS event. The first one, positive predictive value, is the percent of patients arriving at the ER who are actually having an ACS event. In the expanded analysis of alerts data, each ER visit was adjudicated by Harvard University faculty cardiologists to identify which were ACS events that included MIs and cases of unstable angina. As expected from prior studies, where less than 20% of patients arriving with symptoms at an ER have an ACS event or MI, the PPV for alarms off symptom-prompted ER visits was 18.2%. In comparison, a symptomatic patient with an alarm had a 91% higher PPV of 34.8%. For asymptomatic presentation, as expected, they do not exist for the alarms off group, and while 20% may seem somewhat low for alarms in those with alarms, it's as good as the standard of care, and remember, these patients otherwise would never come in. It should be noted that only ACS events were counted as true positives. Many alarm-prompted patients had other non-ACS serious medical conditions that did not count in this analysis. Most important is that the Guardian is the first ever system to prompt presentation for a silent MI. The second measure of accuracy analyzed was the annualized rate of false positive ER visits. As I mentioned, the initial analysis did not include accuracy data to address concerns that the Guardian could induce a significant increase in false positive presentations without an actual ACS event. This concern was not supported by the data, which showed that just having alarms enabled actually decreased the false positive rate by 26%, even when including false positive symptoms only presentations where no alarm occurred. The big surprise was that the false positive rate just for alarm prompted presentations was about 1/4 of that for the alarms off group or the standard of care. The primary goal of the Guardian has always been to get patients having a heart attack to the hospital faster than if they only depended on symptoms to prompt presentation. The next few slides show the impact of alarms on pre-hospital delay. We begin with the alarms off control group representing standard of care, whose adjudicated MIs were identified following patient presentation prompted by symptoms only. The alarms off group with only 40% of MIs presenting in less than 4 hours, had a median symptom to door for MI of more than 8 hours. The alarms off group shown in the bottom curve matches well with the study by Devon that, like alerts, looked at time from initial symptom onset and included late arrivals greater than 96 hours. Both show only 40% of patients arriving in less than 4 hours from symptom onset. In addition, of interest is that while the overall median symptom to door in Devon was 6.2 hours, it was 6 hours for men and 9 hours for women. Prolonged pre-hospital delay has long been a more significant issue for women who are more prone to atypical symptoms and silent MIs. What is the impact on symptom to door for patients alerted by the Guardian? As seen here, nearly 90% of patients having a heart attack who had both symptoms and a Guardian alert reached a medical facility within 2 hours of symptom onset, with a median symptom to door of 1 hour. This is a significant improvement over all other groups without alarms, where only symptoms alone prompted patient presentation. A more than 5-hour improvement over Devon and the alarms off group, and a 1 to 2 hour reduction over the best historical symptom to door data ever published. So alarms get you there faster if you have symptoms, but what if you do not? One cannot measure symptom to door for a silent MI, but alerts data captured alarm to door for silent MI shown here in blue. The median alarm to door time for these silent MIs is 1.4 hours, with more than 75% of the patients arriving within 2 hours of the alarm. The Guardian is the first ever technology that can prompt presentation for silent MI, and when it does so, the patients take action quickly. A secondary endpoint of the expanded analysis was also the ability of the Guardian to prompt patient presentation, resulting in the diagnosis of new onset serious medical conditions. These include both emergency alarm and see doctor alert prompted visits. Nearly 9% of patients had such an additional detection in the 1,500 patient years of data looked at. Those prompted by an emergency alarm counted as false positive for ACS, but were important nonetheless. Alarms also prompted presentation of 46 patients with a new indication for a pacemaker or an ICD. The FDA indication for use is shown here. This broad IFU will allow the Guardian to be used in high-risk post-ACS patients. It's important to note that the Guardian is an adjunct to symptoms, not a replacement for them. It describes the improved accuracy and reduced false positives of the Guardian alerts, and importantly indicates that the Guardian can prompt patient presentation for asymptomatic ACS events, including silent heart attacks. What does this mean for a patient having a heart attack? Here's an example of a Michigan female who at 6:30 in the morning experienced some symptoms. Shortly later, her alarm went off. You can see the tracing from inside showing the comparison of 24 hours before versus the alarm capture electrogram. Within 30 minutes, she's in the ambulance on the way to the hospital. A little changes here, but within 50 minutes, she's completed admission into the hospital, completed a EKG with a significant posterior STEMI showing up in the 12 lead. Rushed into the cath lab, they found a subtotal occlusion in her circumflex coronary. Complete treatment in under an hour and a half. This is the gold standard for what the Guardian will be able to do in the future. I'd now like to turn it over to Dr. Kaplan to talk about what this means to patients and their quality of life.
Post-ACS patients need something. Only a small percentage of MI survivors receive implantable defibrillators, which only offer protection against sudden death. For all other post-ACS patients, there is nothing to help them deal with the fear and anxiety of having a life-ending or disabling event. Recognition of ischemic symptoms may still be challenging for these patients. As the Guardian went through early feasibility studies, patients reported lessened anxiety and peace of mind from having an early warning system, especially one that can help differentiate real from false symptoms. To quantify this, Dr. Neil Oldridge, the creator of the MACNU Quality of Life Survey, used to evaluate cardiac-related quality of life, was asked to help design a quality of life sub-study for ALERT's patients. The study compared pre-implant quality of life with that at 6 and 12 months after alarms were enabled for the patient. The results on the MACNU Cardiac Quality of Life Survey showed clinically significant improvements from pre-implant to both 6 and 12 months after alarms were enabled. This is important as prior studies in post-MI patients have shown no statistically significant improvement in quality of life, even after cardiac rehab or with remote monitoring. Both the MACNU and a custom survey supported the Guardian as the primary cause. This is unique among available therapeutic options for post-infarct care. Shown here are the results from the custom survey that explain the reasons behind the significant improvements seen with MACNU and the peace of mind expressed by most patients. 90% of patients reported feeling safer. They experienced less anxiety and were able to engage more fully in life activities such as exercise. Additionally, they slept better. They felt more in control of their life and felt reassured having an alarm system in place. They like it when they get it, but will patients want it and be accepting of this technology? Approximately 2,000 patients and alerts qualified for the study. Each was offered a long, informed consent form listing all the potential risks of participation. None of the now understood benefits were known or in the consent form. The procedure required surgical implant of the device with a lead in the heart without offering any pacing or defibrillation therapy. And finally, to make it even less desirable, patients had a 50% chance of being in the alarms off group for 6 months. 1,020 patients consented, with essentially no dropouts or patients requesting explants during the study. With the now known and published benefits, I do not expect any challenges finding patients interested in receiving a Guardian device. Thank you.
I'd now like to first have Dr. Tucker and then Dr. Kaplan talk a little bit about what this meant to their patients and to them as cardiologists. Dr. Tucker, please.
Well, on the screen, you see a direct quote from one of our patients, and I think this short statement really summarizes how the device impacts the families. What our patient said was, "For me, the Guardian device is my angel. It's watching over me. For my wife, it's peace of mind, and that also comforts me." And this really sums it up for me. I mean, the patients love this device. It really alleviates their anxieties. Now, I'm a physician in a very competitive market, and to have this kind of breakthrough technology really puts us at an advantage over the rest of the practices in our community. This device is the first ever surveillance tool for patients with prior acute coronary syndrome. And the ability of this device to relieve the patient's anxieties cannot be understated. I mean, the spouses are probably even more positively impacted than the patients themselves. And I got to tell you, that's very gratifying to be the physician able to offer this technology to our patients.
Dr. Kaplan.
Thank you. I have to echo everything expressed by Dr. Tucker. When I have an opportunity to review what the experience of participating in the trial and subsequent care of my patients has meant, several things became clear. What does the diagnosis of coronary artery disease mean to a patient? It can mean mortality, debility, becoming a burden upon others, a loss of autonomy, and a constant fear. I have heard these concerns from many patients. What the AngelMed Guardian has offered them is a safety net, an early warning system to know when things are amiss, and reassurance to know when things are not. Rarely are devices which are not offering a therapeutic intervention so readily accepted by patients, but the Guardian is without doubt the top one I have ever encountered in clinical practice. I have had personal experience with patients who staved off myocardial infarctions because of this device. Every patient in the trial was sorry to see it end and was excited about approval and return of its availability. It truly is a game changer. Thank you.
Thank you, Doctors Tucker and Kaplan. My father, Robert Fischel, co-founder of Pacesetter Systems, which is Abbott's pacemaker company, and one of the inventors of the ICD, conceived this idea more than 20 years ago. My team of gifted former Bell Labs engineers turned the idea into reality, and 5 patients in Singapore have already received the first commercial implants of the AngelMed Guardian, while we've begun to re-implant our US alerts patients. The Guardian has the potential to help high-risk patients with minimal risk. It has a large number of benefits as we presented today, but in summary, it does what it was designed to do. If you have symptoms, it shortens symptom to door time. If you don't have symptoms, it still gets you there. The American FDA wrote in their summary of safety and effectiveness data, the Guardian device fills an unmet medical need by providing more effective diagnosis of a life-threatening condition when compared to symptoms alone. As Dr. David Wones from Spectrum Health in Michigan said in our previous Singapore webinar, all that remains to be said is, it's about time. Thank you very much.
Thank you, David. The average pre-hospital delay for a patient with a heart attack varies between 3 to 7 hours. Even patients with a previous heart attack, the delay is about 2 hours. Now, if a patient comes in with a heart attack to the ER within 2 hours and receives immediate treatment, there's a good chance that the heart attack can be aborted. Or if not, at least the damage will be very much reduced. In a major heart attack, some 5% of patients will succumb within the first 2 hours. Every further 30 minutes delay would increase the mortality by about 7.5%. Why is there so much pre-hospital delay? Well, patients, when they get a heart attack, often adopt a wait-and-see policy, hoping that the discomfort is due to something else rather than a heart attack, hoping it's due to gastric problem or any other thing except a heart attack. Even doctors who get heart attack when they come to the A&E often denies that they have a heart attack. Secondly, some 30% of heart attack patients present no symptoms at all. In fact, in diabetic patients, 60 to 65% of patients with a heart attack in diabetic patients have no chest pain. Now, women with heart attack are more likely than men to present with atypical symptoms such as breathlessness, gastric pain, back pain, and profuse sweating. And lastly, many heart attack occurs in the early hours of the morning, between 6 to 9 a.m., the so-called morning surge. And at this hour, the patients are reluctant to call the cardiologist and will often sit it out for a few hours. An AngelMed Guardian device can accurately detect and diagnose heart attack within 2 minutes. This is going to be a real game changer. For early diagnosis, we can now effectively bring the patient to the cardiac catheterization lab within 2 hours of the onset of symptoms. This can effectively save a lot of lives. It will also reduce the number of visits to the A&E from false alarm. I've had 5 patients for that AngelMed implant in Singapore. All of them are very high risk patients, high risk of getting a recurrent ACS. Suffice to say that all 5 patients have done very well. All 5 patients has that previous ACS event and a previous PCI with stenting. 3 of the patients had a coronary artery bypass graft surgery before. 3 have diabetes, and 1 has renal impairment. Since the implant, all 5 patients feel that the chances of getting a fatal heart attack is markedly reduced. They have now peace of mind, which they've never had before. And their confidence has increased so much that 4 out of 5 have increased their physical exercises and activities by a long way. So AngelMed Guardian is clearly addressing a huge unmet need. I shall now open the discussion to our panelist members.
I think I will address. First, it was, can I explain why the FDA approved the AngelMed Guardian even though the original analysis primary efficacy endpoint was missed? The FDA, as most of you know, is charged with considering the totality of the data. And as with many new technologies, FDA often asks for additional data before approving such a new technology. For the AngelMed Guardian, the FDA, as I mentioned earlier, requested accuracy data that showed the Guardian was more accurate than symptoms alone. This, in combination with the lower false positive rate, the ability to prompt presentation for silent MI, and reduce symptom to door times, convinced the FDA that the benefits outweighed the risks, allowing for the device to be approved.
Let me add something to that question. Though FDA approved the Guardian in 2018, why does it need reapproval? I don't think many people realize what has happened.
Sure. We replaced the battery that lasted only 3 years with one that will last 6 to 7 years. And the FDA asked us to do one additional test, which is finishing, I think, in a week or two, before they approve what is called a PMA supplement to let the new battery be used. And it's better, much better for the patients to have a device that doesn't need to be replaced every 3 years. So we've all moved forward to get this going, and we'll be commercializing it in the US this year.
Is there a specific time do you think you'll get the new?
Well, I'm hoping in the second quarter.
I see. Okay, well, we are using the one with the new battery, which is very good. Thank you.
Only that one. It's a better thing for the patients.
So far, we've just added in another case, 6th case, and we are doing this 7th case next week. Thank you.
Hi, this is C.K. Ching. I'm a heart rhythm cardiologist at National Heart Center. Thank you for the wonderful talk. I'm very intrigued, and consistent with implantable devices. When you make the supervision or monitoring automatic, it picks up more events. I have a few questions. In your latest study, which recruits close to 1,000 patients, there's obvious short and significant symptom to door time. I would like to know, in patients with a Q-wave MI or with an ACS detected via the ALERT study, how many actually had occlusive coronary artery disease versus non-occlusive? For example, non-ST elevated MI versus an ST elevated MI. That's number one. Number two, I do not recall seeing the 38. The adverse events like death and recurrent MI or any of the MACE. Were there any significant difference between these two groups? Thank you.
The number of deaths was very, very low. And that was also one of the issues with the original primary endpoint. We had hoped there'd be a lot, more deaths in the control group. And the other issues, of course, 6 months is just not enough time to get enough events. The whole reason we included more. There were 89 detected ST shift events that were adjudicated as ACS events in 1,500 patient years of device enabled patients. They were split between STEMIs. I think there were 12 STEMIs. There were, a third of them or half of them were NSTEMIs, and the rest were unstable angina. And they were kind of divided among those. But one of the interesting thing is 42 of those were silent, had no symptoms whatsoever, which, if you think about it, is right in line with the concept that really out there, we are way undercounting silent heart attacks. And it could be as high as half of them have no symptoms. I hope that helps.
All right, thank you.
Professor Philip Wong, you have a question there.
Yeah, my name is Philip Wong. I'm also from the National Heart Center of Singapore. I'm an interventional cardiologist. My take on this device is extremely interesting. I think not only because it gives a forewarning, but the method that it gives the forewarning. I think now in a period of COVID-19, patients are actually quite apprehensive to come to hospital. So they tend to delay the time to presentation to emergency rooms and so on. So the idea, I think, is excellent. The thing is, I just wanted to ask Leslie, because he has the most experience with implants, what is the cost of the device, and what do you think is eventually the long-term cost benefit to patients of having this device? If you can, sort of make that discussion.
Okay, I can tell you what the cost is. The cost today in Singapore is $12,000 for the device and the electrode, and then plus whatever cost you implant. The government, the health authority, has to decide the table of surgery procedure code. They haven't come to a code yet, and as such, we cannot get the insurance company to agree on what the amount is. But it would not be more than what the cost of pacemaker. As to the cost effectiveness, I think, David, you have to take that on up. I'm not sure of how cost effective, the long-term cost effectiveness of the devices.
Well, it's hard to know. There's a lot of data out there on even things like saving 40 minutes in time to door has huge impacts on length of stay and on size of infarct. A reduction of 26% in the number of patients coming in thinking they're having a heart attack who are not over a 6-year life device could have an impact saving money for the payers. And finally, the real goal here is if you can get people to the hospital faster and reduce infarct size, you're going to dramatically reduce congestive heart failure. And as you know, at least in the United States, that is the biggest expense to our healthcare system, is all these patients getting congestive heart failure because they never got to the hospital, either for a silent MI or they didn't get there fast enough when they had symptoms. So we think ultimately there will be a large impact. We've begun with just using the time and the reduction in false positives, but those are the two things that I think will ultimately show a cost benefit to the systems.
Well, if it can save life, how much is a life worth? I don't know. It's very difficult to put the cost on this. Question for Dr. Tucker. Where and when is a Guardian most likely to miss a heart attack?
Well, the accuracy of the device, the ability of the device to detect EKG changes is linearly related to infarct size. So if you have a situation in which a very small branch vessel is involved and only a very small amount of myocardium is involved, then those changes are going to be more difficult for the device to detect, and you might get a false negative in that situation. This could also occur in areas that are well collateralized by other vessels, either from collateral flow from the other side of the heart or bypass vessels. But it really is limited to smaller events, less clinically relevant events. And if you're having a larger event, then it's much less, more unlikely to be a false negative.
For Dr. Kaplan, the Guardian does provide a psychological well-being and a safety net for patients. Certainly in all my patients, they have never been felt so safe. They're so pleased with the device that they think this is the best thing that's ever happened to them. So I can speak from personal experience on my part. Can the patient exercise to a point where, let's say in a treadmill stress test, the ST segment comes down, positive treadmill, can that trigger off the Guardian device?
There certainly may be alarms related to ST segment changes which occur during exercise, such as in a treadmill stress test. The templating that Dr. Fischel spoke of that takes place between the time of implant and when the patient comes in for their incision check helps to teach the device what ST segments are appropriate at each given level of heart rate. So there's binning of the ST segments at different heart rates. And then the artificial intelligence system within the programmer and the device help to set those baseline levels. The alarm then would only occur if there were significant changes in ST segments beyond those. So in effect, yes, you are allowing for an ambulatory stress test for the patient if they happen to be doing exercise outside of your office. And certainly, just like you would see in a typical coronary patient, if they were performing a stress test in the office and reached a point of ischemic threshold, you would see ST segment deviation occurring there in the same manner.
Dr. Kevin Wong, you have a question there. Are you receiving me?
Can you tell us more of your experience of the patient acceptance of this implant in Singapore in your 5 to 6 case series?
Oh,
Dr. Lam, maybe
total acceptance. Absolutely. I've been seriously, they've never been so pleased. Sorry.
Let me add to the question. I'd like to find out what are some of the barriers in your experience in offering this therapy to patients.
No, I offer it to patients who are really high risk patients, patients who have had previous AMI, patients of previous CABG and multiple stents and so on. A lot of these patients feel that another major heart attack they may not survive if they don't get in the hospital in time. With this device in, they feel so absolutely peace of mind. They feel that they are going to, if they get a heart attack, they are going to get in the hospital in time. I can put a stent in time. I can do a PCI in time, and they can save his heart and save his life. To them, this is the best thing that's happened to them for a long, long time. So this device, as time goes on, if we select the patients correctly, this device would be a godsend to them. Does that answer your question?
Got one last question, which is, how well does the Guardian device perform in diagnosing MI in different territories between the LAD, circumflex, and RCA? Is there any difference? We understand the vector for monitoring is CAN to RV tip. What we've learned over working on this in 20 years, first in animal and then people, oops, that's the end. Is that the RV apex is the best place to do it. Thank you.
I'm not sure if going to have time to answer the question. I think we've just been told that our time is up. Thank you very much, everybody. Thank you for your time, and best wishes in the US. I hope we are doing as well as we are doing in Singapore with the COVID. Take care, everybody.